Refractory rickets, familial hypophosphatemic rickets. Normal level of serum phosphate is essential for the mineralization of the growth cartilage. Some inherited clinical disorders include lead to excessive loss of phosphate in the urine with low serum phosphate levels and can present as refractory rickets. So what happens is the person has rickets and we start vitamin D treatment, okay, the stars treatment or any other normal regime. But then what happens is we wait for the response, 4 weeks no response, 6 to 8 weeks no response, and then we're going to find out what's wrong. And I mean, clearly, if there's no response to vitamin D, we know that it is a refractory rickets. So what we do is we take the serum phosphate level and check. If the phosphate level is low, we know there's a problem. Okay. If the phosphate level is low, but then the calcium and the PTH level are all normal, then we know it's a familial hypophosphatemic rickets. Sorry. Yeah, so this is X-linked dominant disorder with variable penetrance, but rarely sporadic and autosomal recessive can also occur, but mainly it's going to be X-linked dominant. Pathogenesis, there's this gene, it's called the FEX gene. Okay, FEX stands for PH is phosphate, EX E is endopeptidase, X is X chromosome. So FEX is phosphate regulate. Okay, PH is phosphate, E is endopeptidase, and X is X chromosome. So the full form of it is phosphate regulating gene with homology to an endopeptidase on X chromosome. So it's a phosphate regulating gene similar to endopeptidase and it's located in the X chromosome. Alright. So this enzyme is responsible for the breakdown of FGF23. FGF stands for fibroblast growth factor. What happens is usually if the FGF3 that is FGF23 is going to be elevated, what happens is the 1 alpha hydroxylase activity will be reduced. Okay, so the yeah, so what happens is the blood D3, that is the calcitriol, will be low even though hypophosphatemia is there, because low phosphate level, low calcium level, these are all triggers for vitamin D to rise in the blood. Okay, but then despite the fact that the phosphate is low, vitamin D3 is not going to reduce. Sorry, it's not going to increase. Why? Because 1 alpha hydroxylase activity is reduced. 1 alpha hydroxylase enzyme is not reduced here. Point to be noted, in VDDR type 1 only the 1 alpha hydroxylase is reduced. But here because the FGF23 is increased, the activity of the 1 alpha hydroxylase is down regulated. That is the problem in case of the FHR, familial hypophosphatemic rickets. Okay, so there's this FEX gene. FEX gene produces an endopeptidase. This endopeptidase enzyme is responsible for the breakdown of FGF23. And because this endopeptidase is not there, FGF23 is going to get elevated. And this FGF23, if it's elevated, it's going to inhibit the 1 alpha hydroxylase. If 1 alpha hydroxylase is inhibited or if its function is reduced, it's going to not perform the normal function of converting D2 to D3. That is, calcidiol to calcitriol will not happen. So we'll see the clinical features. Clinical features, mainly we are going to look at lower limbs and the maxillofacial problems. Okay. Okay, we're going to divide it into three actually. Lower limb, maxillofacial, and dental. These are all like the skeletal problems. Lower limb deformities include coxa vara, genu valgum in short stature. Okay, so okay, if the phosphate level is less, the person's height is also less. Remember that way. As about the lower limb, the maxillofacial region, there's abnormalities, and then there is premature closure of the cranial sutures, which lead to deformities of the skull, like dolichocephaly and all. Check out my other video. Dental abnormalities can also be seen, including pulp abnormalities, like pulp deformities with intraglobular dentine and frequent dental abscess. There will be tetany, muscle weakness because of hypocalcemia. And then evaluation, we are going to look the blood levels. So phosphate is low, the calcium is normal or it's slightly low, alkaline phosphatase is high. And then treatment, okay. PTH is also normal. PTH is normal, calcium is normal, alkaline phosphatase is high, phosphate is low. Management, oral phosphate and vitamin D supplements are the mainstay treatment. Phosphate doses 30 to 50 mg per kg. Julie solution is given. Julie solution is 30.4 mg.